So, hello everyone, and welcome to the case 10 of this case discussion series. And today we'll be discussing a very important case. So, here we have a 45-year-old female who presented with paralysis of the left extraocular muscles, which was acute in onset with a severe headache, and she was a chronic hypertensive on medication. And this is the MRI brain axial section T1 weighted images of this particular patient, where we can see that there is some hyper intense outpouching from the vessel in the basal cistern, in the interpeduncular cistern. We can see this particular outpouching, which is hyper intense on T1 weighted images. On T2 weighted images, axial section, we can see that the same outpouching is a bit heterogeneous with both hyper intense and hypo intense signal. So this is the angiography images to determine from which vessel it is actually arising. And here we can see that this is the ICA, left ICA, and at the origin of the left PCOM from the ICA, this aneurysm is actually arising, and it is actually having some mass effect on the adjacent midbrain, the large outpouching, and involving the entire left posterior communicating artery. And these are the reformatted images. All credits to my technician Rajveer ji. So we can see that the left PCOM is completely involved, and it is actually thrombosed, giving a heterogeneous signal on all the sequences. So this is the report that had given that there was a saccular outpouching noted in the origin of left PCOM from the ICA involving the entire left PCOM, and it was seen as a heterogeneous rounded structure on all the sequences, suggesting partially thrombosed aneurysm. And the non-thrombosed part of the aneurysm was seen at the origin of the left PCOM from the ICA, while the thrombosed part appeared predominantly hyperintense on T1 and T2, indicating a subacute thrombosis, and is located and was actually located in the left PCOM, causing mild mass effect on the ipsilateral midbrain. The diameter of the neck of the aneurysm was 3.1, and the dome width was 13.6, and the height of the aneurysm was 19.2 mm, with aspect ratio of 6.1, suggesting a high risk of rupture. So what is the pathobiology of a cerebral aneurysm? So the natural history includes genesis, enlargement, and eventually rupture of the aneurysm. The disrupted balance between the local hemodynamic stress and the arterial wall strength leads to formation of the aneurysm, and eventually the proteolysis of the arterial wall by MMPs and chronic inflammation because of the stasis of the blood leads to progression of the aneurysm, and eventually the aneurysm ruptures. So these are the factors that contribute to the aneurysm formation and the growth of the aneurysm. The genetic factors include autosomal dominant polycystic kidney disease, Ehlers-Danlos disease, and such connective tissue disorders. Then there are hemodynamic factors like hypertension, then environmental factors, and then chronic inflammation because of stasis of the blood. So histology also plays a very important role in the formation of the aneurysm in the vessels. The intracranial arteries, the intracranial part of the internal carotid artery to the terminal branches, they lack the external elastic lamina, which is present between the adventitia and the media. Secondly, the thickness of the media and adventitia is 1/3 of that of the extracranial and the systemic arteries. And then the bifurcation of the cerebral arteries, the three things happen. There is no media at the apex of the bifurcation. There are tears in the internal elastic lamina at the bifurcation, and at the site of tear there are pads of myointimal hyperplasia. All these contribute to formation of aneurysm. So what are the risk factors for rupture of the aneurysm? So we have to discuss about aspect ratio, dome to neck ratio, and dome height. So in my report, as you have already seen, that I had given aspect ratio, I had also given neck width. So all these things are important. Why? Because aspect ratio more than 1.6 suggests increased risk of rupture, and aspect ratio is calculated by height by neck of the particular aneurysm. Dome to neck ratio less than 2 and neck dimension more than equal to 4 mm suggests a wide neck, and hence coiling will be difficult. And the size of the aneurysm is considered usually the height of the aneurysm. Then the risk factors for rupture include a size of more than 10 mm, location in ACOM or PCOM more likely than MCA, the shape of the aneurysm, if it is irregular with daughter sacs or blebs, it is suggestive of high risk of rupture. Then aspect ratio more than 1.6 causes stasis of the blood and then chronic inflammation. Then increasing size on serial imaging and previous SAH from another aneurysm also contributes to increased risk of rupture.